And now we're going to move on to anthrax, and Dr. Stevens is going to lead the way.
Good morning. It's my pleasure to present on behalf of the Anthrax Working Group. These are the working group members, including myself and Robert Atmar, and new member Sharon Fry to our group as ACIP members, and the rest of the working group, Willie Bauer, who will present in a few minutes, has been our lead. So this working group was reconvened in March of 2017 to discuss new data published since the last review of anthrax vaccines in 2010. Anthrax vaccine is unique compared to vaccines usually reviewed by ACIP. One of the issues under discussion is the use of anthrax vaccines for post-exposure prophylaxis in the event of Bacillus anthracis being used as a bioweapon. The U.S. government stockpiles anthrax vaccine for the use in the event of widespread release of B. anthracis spores in densely populated areas. To effectively provide vaccine in this situation, decisions are needed on how to provide the vaccine and to whom it should be given quickly. For this reason, decisions on how to best use the vaccine should be well vetted prior to such an event. CDC is asking for ACIP's advice on policies that would be implemented to improve the efficiency of mass vaccination campaigns in the event of a widespread release of spores. So today's session will have several parts. There will be a great evaluation of the evidence, and then 3 questions that are under consideration. One is route of administration. May the intramuscular IM route of administration be used if subcutaneous route of administration presents clinical, operational, or logistical challenges that may delay or prevent effective vaccination? Second is dose-sparing schedules. Should there be an inadequate supply of vaccine for anthrax vaccine available for PEP, may either 2 full doses or 3 half doses of AVA be used to expand vaccine coverage? The third question is antimicrobial duration. Can the duration of antimicrobial component of PEP be decreased to less than 60 days when given in conjunction with the AVA vaccine? So with that introduction, I'll turn the presentation over to Dr. Bauer.
Thank you for that introduction, Dr. Stevens, and good morning to everyone. And I would like to thank the ACIP committee for allowing me to present to you some policy change considerations for anthrax vaccine. Before we go into the grading of the evidence reviewed by the Anthrax Vaccine Working Group, I would like to explain how the data was used to support the policy changes we are presenting to the committee. Inhalation anthrax is very rare, so we cannot directly assess the effectiveness of anthrax vaccine absorbed, or AVA, for post-exposure prophylaxis in humans. For this situation, the FDA has recommended using the animal rule, where data from animal studies are used to generate a correlate of protection model based on immune response measured in animals following vaccination. Then the data from human studies on immune response can be used to estimate human survival based on antibody concentrations generated by the vaccine in humans. The predicted human survival data are all indirect measures, since it is derived from a comparison of human to animal data, and therefore the grade evaluation supporting the evidence was downgraded. The animal study data came from a study in non-human primates given serial dilutions of AVA to generate a range of anti-PA IgG concentrations and then challenged with Bacillus anthracis spores. The antibody concentrations and survival data were placed into a model to generate a survival curve. Two other non-human primate studies using slightly different vaccine schedules or vaccine dilutions and dosing schedules supported the findings of this model. The human immunogenicity data came from two main sources. The Wright study directly compared the intramuscular to subcutaneous route of administration for immunogenicity and adverse events when given on a pre-exposure prophylaxis dosing schedule. The human immunogenicity data for the dose-sparing schedules came from the Bernstein study that directly compared the antibody concentrations generated by the dose-sparing schedules we are considering to the antibody concentrations generated by the licensed dosing schedule. The data to support a decrease in antimicrobial PEP duration came from these studies, plus others that looked at immunogenicity of AVA when given on a licensed dosing schedule. Now I'd like to go over a summary of the policy questions for ACIP to consider today. The policy questions are all related to use of AVA as post-exposure prophylaxis. The first two questions for ACIP to consider are to optimize the vaccination process in a large mass vaccination event. These policy changes would allow the use of the intramuscular route of administration if the subcutaneous route of administration posed significant clinical, operational, or logistical challenges that might delay or prevent effective mass vaccination. The second policy question is to allow the use of dose-sparing strategies if the demand for vaccine exceeds vaccine supply. The third question is related to the duration of antimicrobial use in conjunction with vaccine. Now I will present the grade for the evidence supporting the proposed policy changes. As discussed earlier, we cannot directly assess the effectiveness of AVA for post-exposure prophylaxis in humans and must use the correlates of protection model to estimate human survival at the anti-PA IgG antibody concentrations generated by the vaccine. The antibody concentration and survival data came from the Sivko study in which non-human primates were given threefold serial dilutions of AVA at 0 and 14 days to generate a range of anti-PA IgG concentrations. The animals were then challenged with an average of 205 LD50 Bacillus anthracis spores on day 28. The antibody concentrations and survival data were placed in a logistic regression model to generate a survival curve. The two other non-human primate studies, which used slightly different vaccine dilutions and dosing schedules, supported the findings in the Sivko study. As I stated before, the human data came from two main sources. We have a study, the Wright paper, that directly compared the intramuscular to subcutaneous route of administration for immunogenicity and adverse events when given on a pre-exposure prophylaxis dosing schedule. From this study, we looked at a subset of the data where the vaccine recipients received AVA at 0, 14, and 28 days, which is the post-exposure vaccine schedule. The human immunogenicity data for the dose-sparing schedules came from one study, the Bernstein paper, that looked at AVA given as 2 full doses at either 0 and 14 days or 0 and 28 days, or 3 half doses given at 0, 14, and 28 days. Other studies supported the findings of the Wright study that looked at immune response and adverse events with vaccine given by either the IM or the subcutaneous route. These papers listed here also supported the findings in the Bernstein paper. All studies listed on this and the previous slides were used to inform the considerations on decreasing the antimicrobial duration when given in conjunction with AVA. Now we will look at the grade evaluation of the evidence on the first policy question. In a mass vaccination event, can the intramuscular route of administration be used if the subcutaneous route of administration poses significant clinical, operational, or logistical challenges that might delay or prevent effective mass vaccination? We conducted a systematic review of the literature with the following parameters. Adults 18 to 65 years old that received 3 doses of AVA administered intramuscularly at 0, 2, and 4 weeks, and compared to AVA administered subcutaneously also at 0, 2, and 4 weeks, which is the current licensed route of administration. The outcomes of interest were immunogenicity and adverse events. The Wright study was the only paper that directly compared IM and sub-Q route of administration for immune response and adverse events and received a grade of 1. In addition, there were 3 other randomized controlled trials and 3 observational studies that looked at intramuscular or subcutaneous route of administration separately and supported the findings in the Wright study. These papers were all downgraded for benefit because they were not a direct comparison between the IM and sub-Q route of administration, and the survival benefits were derived from an indirect comparison of human and animal data. The overall evidence grade for benefits of immune response for IM compared to subcutaneous route of administration was 2, and for adverse events was 1. Now we will look at the grade evaluation of the evidence for the second policy question. In a large mass vaccination event, can dose-sparing schedules be used to extend vaccine coverage? A systematic review of the literature was performed to look for papers where healthy adults 18 to 65 years of age received dose-sparing schedules of AVA and anti-PA-IgG concentrations were measured at time points prior to 60 days after the first dose of vaccine. There was one paper that met this criteria. Once we had the immunogenicity data, we could use the correlates of protection model described above to predict survival for the dose-sparing schedules compared to the current licensed schedule. The data on the different dose-sparing strategies all came from the same sources, so all are listed together here. The Bernstein paper looked at the dose-sparing schedules in healthy adults, was downgraded because of indirectness of the as the data is compared to non-human primate antibody concentrations and survival data. However, was upgraded due to the strength of association and dose response gradient. The final grade for the human immunogenicity data is 1. The Sivko paper used to generate the non-human primate antibody concentration and survival curves was downgraded by 2 for indirectness because the data was used to estimate human response and placed into a model to predict survival. However, the evidence was upgraded due to strength of association and dose response gradient. The overall grade for the non-human primate immune response is 1. However, given the overall indirectness of comparing human and non-human primate data, the overall evidence grade is 2 for the benefit of dose-sparing strategies. Harm was not a factor in this question. Now we will look at the grade evaluation of the evidence for the third policy question. Can antimicrobial duration of PEP be decreased to 42 days after the first dose or 2 weeks after the last dose of the vaccine series, whichever is last? Our systematic review of the literature for this question was similar to the prior review. We looked for papers where humans received AVA on a post-exposure prophylaxis dose-sparing schedule or AVA on the licensed PEP dosing schedule where anti-IgG concentrations were measured at time points prior to 60 days after the last dose of vaccine. Since our systematic review of the literature for this question was similar to the prior review, the grade was also similar. The data for the dose-sparing strategy immune response was grade 1, and the non-human primate immune response and survival data was grade 1. However, again, given the indirectness of comparing the human and non-human data in a correlative protection model, the overall evidence grade is 2 for the benefits of decreasing the duration of antimicrobials when given in conjunction with dose-sparing strategies. Again, harm was not a factor for this question. There were 6 additional studies, 4 randomized controlled trials and 2 observational studies that supported the data of the immune response in humans for the licensed PEP dosing schedule at time points prior to 60 days. So we felt better about the evidence for decreasing the antimicrobial duration when using the licensed schedule. However, again, given the indirectness of the comparison of the human to non-human data, the overall grade for the benefits of decreasing the antimicrobial duration in conjunction with the licensed PEP schedule is, again, 2. Here is the grade summary for the question on if the IM route of administration can be used as an alternative during a mass vaccination campaign. The overall grade is 2 for benefits and 1 for harm. For the question on dose-sparing strategies and antimicrobial duration for PEP when used in conjunction with vaccine, the overall grade was a 2 for benefit and harm was not assessed. So that is the presentation on the grade. If there are any questions, or if not, I could move on to the next presentation.
Are there any questions? Okay, let's go ahead to the next presentation, if that's okay.
Okay. Now I'm going to discuss the anthrax vaccines work group deliberations on potential policy changes to anthrax vaccine absorbed, or AVA, used for post-exposure prophylaxis. But first, let's review the current indications for AVA. The following recommended uses of AVA came out of the last ACIP review in 2010. First, AVA is recommended for preventing infections in persons before exposure to Bacillus anthracis given by a 5-dose series administered by the intramuscular route at 0, 1, 6, 12, and 18 months, followed by an annual booster. This is called pre-exposure prophylaxis, or PrEP. Second, AVA is recommended to prevent infection after exposure to aerosolized Bacillus anthracis spores by administering a 3-dose series by the subcutaneous route at 0, 2, and 4 weeks in conjunction with 60 days of antimicrobials. This use is called post-exposure prophylaxis, or PEP. As of 2010, the FDA had not approved the PEP indication for AVA, so it was to be used under an IND or possibly under an EUA for this indication. Since the last ACIP review of AVA, there has been slight modifications to the licensed indication. In 2002, FDA approved a change in the PrEP priming series from 5 doses over 18 months to 3 doses over 6 months, followed by boosters at 12 and 18 months and annually thereafter. This was based on data that showed predictive antibody concentrations were obtained by 6 months. This allowed for work in environments with potential exposure to Bacillus anthracis to begin sooner. In 2015, AVA was licensed for PEP in persons who have been potentially exposed to aerosolized Bacillus anthracis spores. For this indication, it is given in a 3-dose series administered subcutaneously at 0, 2, and 4 weeks. Antimicrobials are to be co-administered for 60 days. We will add these changes to the updated policy recommendations to align them with the licensed indications. AVA is currently licensed for persons aged 18 through 65 years of age. There is little to no data on the use of AVA in children, pregnant women, or geriatric populations. However, the benefits of preventing anthrax in persons potentially exposed to aerosolized Bacillus anthracis spores is believed to outweigh the potential unknown adverse events from receipt of the vaccine. The American Academy of Pediatrics and the American College of Obstetricians and Gynecologists both recommend using the vaccine as recommended for the general population under the appropriate emergency use protocols. The policy changes discussed here will apply to all populations except where explicitly stated otherwise. The work group reviewed new AVA safety data published since the last ACIP review. All but one of these studies listed here showed no association between receipt of AVA and the measured adverse outcome. The one study listed at the bottom that showed a potential adverse event suggested an association between onset of rheumatoid arthritis and receipt of AVA. The authors felt that since there was no association with long-term onset of rheumatoid arthritis, that AVA might have triggered an earlier onset in persons who would have eventually developed rheumatoid arthritis. The work group felt that there were no new safety concerns based on VAERS review or data published since AVA was last reviewed. These data continue to support the safety of AVA for use as pre-exposure and post-exposure prophylaxis, given the high mortality associated with anthrax. The work group felt that more data are needed to evaluate the safety of AVA in pediatric populations. You have seen this slide before, but I believe it is important to reiterate the study design used to generate the data reviewed by the work group. As we discussed before, inhalation anthrax is so rare that we cannot directly assess the effectiveness of AVA for post-exposure prophylaxis in humans. Because of this, FDA has recommended using the animal rule. This allows bridging of data from animal and human studies to determine correlates of protection and subsequently to estimate human survival based on post-vaccination antibody concentrations. The Sivko study was used to generate a range of anti-PA-IgG concentrations and survival data to produce the survival curve for the correlates of protection model. 2 other animal studies supported the data derived in the Sivko study. The Wright paper provided a direct comparison between the immunological response and adverse events for AVA given by the intramuscular and subcutaneous route of administration. These data informed the decision on the alternative route of administration. The human immunogenicity data for the dose-sparing schedule came from the Bernstein paper that compared the dose-sparing schedules we are considering today. The data to support a decrease in antimicrobial PEP duration came from these studies, plus others that looked at immunogenicity of AVA when given on the licensed schedule. Now I'm going to give you an example of how this works. This is a Koberger model for bridging animal and human data to determine correlates of protection, and the model the FDA recommends for predicting human survival based on antibody concentrations generated in animal studies. The non-human primates were given AVA at 0 and 14 days. On this graph, the x-axis shows concentrations of anti-PA antibody levels at the time just prior to the challenge with around 205 LD50 Bacillus anthracis spores on day 28. The non-human primate survivors are represented by the black circles at the top of the graph, and the non-survivors are represented by the white circles at the bottom. We then plot a logistic regression curve to estimate survival. The probability of survival is on the y-axis based on the non-human primate anti-PA IgG concentrations. The blue triangles at are the human anti-PA IgG concentrations at day 42 after receiving half-dose AVA at 0, 14, and 28 days. Now, by plotting the individual probabilities of survival and taking the average, we get a mean survival for the population. In this example, the probability of survival at day 42 after receiving half-dose AVA at 0, 14, and 28 days is 96.1%. Again, here's a summary of the policy questions for ACIP to consider today. The policy questions all pertain to the use of AVA as post-exposure prophylaxis. The first two questions for ACIP to consider pertain to ways to optimize vaccination in a mass vaccination event. The third question relates to duration of antimicrobials used in conjunction with vaccine. Now we will look at the work group deliberation on the first policy question. In a large mass vaccination event, can the intramuscular route of administration be used if the subcutaneous route of administration posed significant clinical, operational, or logistical challenges that might delay or prevent effective mass vaccination? The antibody concentrations were significantly lower at day 28 following receipt of AVA given by the IM route compared to the subcutaneous route. However, using the correlates of protection model discussed earlier, the estimated human survival is very high at this time point and only 3.8 percentage points different from the subcutaneous route. In addition, at this time point, as long as they are adherent with recommendations, the vaccine recipients should still be protected by the antimicrobials that are given in conjunction with the vaccine. By day 56, the antibody concentrations and predicted survival for AVA given by the IM and subcutaneous route are no longer significantly different. The subcutaneous route of administration produced significantly more frequent localized adverse events in most all parameters evaluated. For systemic adverse events, the intramuscular route of administration had a higher occurrence of generalized muscle aches compared to the subcutaneous route. Otherwise, there were no other statistical differences for systemic adverse events. Here are some of the operational concerns related to a mass anthrax vaccination campaign. Data from anthrax event in 2001 suggests that adherence to the antimicrobial component of PEP wanes over time and could be as low as 50% by day 30 of the 60-day antimicrobial PEP recommendation. Higher antibody concentrations achieved by the subcutaneous route of administration could predict could protect persons who were not adherent to the antimicrobial component of PEP. However, these studies on adherence were done in a unique situation and may not be generalizable to a mass exposure event if it occurred today. The higher rate of localized adverse events for the subcutaneous route of administration raises concerns that individuals may not return for subsequent vaccine doses. In order to administer a vaccine to a large number of people during a mass casualty event, we need the most efficient method available. Most routine vaccines are given by the intramuscular route, and healthcare providers are more accustomed to giving intramuscular injections. Because there is more experience in the healthcare community given intramuscular injections, this route might be more effective or efficient for quickly vaccinating large numbers of individuals. In addition, many state and local jurisdictions plan to use just-in-time training for persons to administer AVA during a mass vaccination event. When surveyed, they stated that the IM route is easier to teach and thus may be more efficient. The work group preferred the subcutaneous route of administration over the IM route of administration due to the higher antibody concentrations at week 4 that would provide higher levels of protection to individuals who were not adherent to the antimicrobial component of PEP. Thus, this route of administration should be used whenever possible. However, when balancing the operational concerns of administering vaccine to a large number of people over a short period of time, the work group agreed that AVA for PEP may be administered using an intramuscular route if the subcutaneous route of administration posed significant material, personnel, or clinical challenges that might delay or preclude vaccination. The work group also thought that it was acceptable for individuals to receive the vaccine by the intramuscular route if they had experienced significant adverse events from AVA administered by the subcutaneous route. Now we will look at the work group deliberation on the second policy question. In a large mass vaccination event, can dose-sparing strategies be used to expand vaccine coverage? This graph shows the human anti-PA IgG concentration over time with the various dose-sparing strategies reviewed by the work group. AVA given as 2 full doses at 0 and 14 days is represented by the blue line. AVA given as 2 full doses at 0 and 28 days by the orange line, and AVA given as 3 half doses at 0, 14, and 28 days by the yellow line. The license schedule, 3 full doses at 0, 14, and 28 days is represented by the purple line. The dashed line represents the antibody concentration that provides an estimated 80% level of protection as determined from the correlates of protection model. This graph shows that the 3 groups that received a dose at day 14 have higher antibody concentrations at day 28 than the 1 group that did not. 2 full doses 28 days apart produce the highest antibody concentrations from day 42 onward. The 3 full doses produce higher antibody concentrations than the 3 half doses. Peak antibody response is 2 weeks after the last dose for all the schedules, and the peak response is estimated by the correlates of protection model to be highly protective. The first row in this table shows the predicted survival at day 20. Shows that the predicted survival at day 28 is high for the groups that received 2 doses, but is low for the 0-28 full course group or full dose group that had only received one dose at that time point. The next two rows show that the predicted survival is very high at day 42 for all dosing schedules and continues at a high level of predicted survival through day 63. The work group agreed that all dose-sparing schedules provide high levels of estimated protection 2 weeks after the last dose, and the protection was only slightly less than the estimated protection provided by the licensed schedule. Thus, it seems reasonable that in an actual or impending vaccine shortage, the benefits of providing protection to a larger number of individuals outweigh the risk of slightly lower protection levels. The selection of the dose-sparing strategy to implement depends on the anticipated shortage. The two full-dose strategies will expand the vaccine supply by 50%, and the 3 half-dose strategies will expand it by 100%. Now we will look at the work group deliberation on the third policy question. May antimicrobial duration of PEP be decreased to 42 days after initiation of vaccine, or 2 weeks after the last dose of the vaccine series, whichever is last? This is the same slide or graph that you saw before, but with lines at day 28 and 42. These are the 2 time points the work group evaluated when considering shortening the antimicrobial duration. Again, this graph shows the human anti-PA IgG concentrations over time with the various dose-sparing schedules and the current license schedule. Again, the dashed line represents the antibody concentration that provides an estimated 80% level of protection determined by the correlates of protection model. The vertical line at day 28 is when individuals receiving the last dose, if using the license schedule or the proposed dose-sparing schedules, except for the day 014 dose-sparing schedule. The line at day 42 is 2 weeks after the last dose for all the schedules that end on day 28, and 4 weeks after the end of the 0 and 14 day dose-sparing schedule. This table shows the estimated protection at days 28, 42, and 63 for the dose-sparing schedules reviewed by the work group, and also the license schedule. The estimated peak protection for all schedules occurred 2 weeks after the last dose. This is estimated to be highly protective and is maintained through day 60 when antimicrobial component of PEP is currently recommended to end. Note that the animal studies used to develop the estimated levels of protection used a high-dose challenge at day 28 with no antimicrobials, whereas humans in a exposure scenario would only have residual spores 4 to 6 weeks after the initial exposure. So this is considered to be an extremely conservative worst-case estimate. For most of the dose-sparing schedules, as well as the license schedule, 42 days is 2 weeks after the last dose, and for the 0 and 14-day dose-sparing schedule, day 28 is 2 weeks after the last dose. The peak response occurs around 2 weeks after the last dose for the current license schedule and all the dose-sparing schedules. The peak response in all the schedules is estimated to be highly protective. However, even though the peak response is at day 28 for the 0 and 14-day dose-sparing schedule, the work group advised continuing antimicrobials for 42 days to allow for additional clearance of the residual spores from the lung. Discontinuation of the antimicrobial component of PEP once peak immune response is reached would shorten the antimicrobial requirements and potentially reduce adverse events related to continued antimicrobial use. Shortening the duration of the antimicrobial component of PEP might improve adherence. The work group felt that the antimicrobial component of PEP could be discontinued at 42 days after initiation of vaccine if given on schedule for both the licensed and dose-sparing schedules. However, it is important to note that the second dose of vaccine is critical to producing high antibody concentrations, so to take into consideration that in an emergency situation, the vaccine may not be given exactly on schedule, the work group advised that in immunocompetent individuals, antimicrobials should be continued for at least 42 days after the first dose or 2 weeks after the last dose in the vaccine series, whichever comes last. Since there is no reason to suggest that giving vaccine should lengthen the need for antimicrobial PEP, the work group saw no need to continue antimicrobials past 60 days, which is the recommended length of antimicrobial PEP when not given in conjunction with vaccine. The above recommendations is for otherwise healthy 18 to 65 years old, persons with an immunocompromising condition that might interfere with their ability to develop an adequate immune response, or populations where there is no data on immune response, such as those 65 years and older, should continue to receive antimicrobials for 60 days concurrently with vaccine. Some of the work group members felt that despite the lack of data, there is also no evidence to suggest children would not have a robust immune response to AVA. A minority of the work group members felt that decreasing the duration of antimicrobials as described above could be extended to otherwise healthy children 2 to 17 years of age. Here is a summary of the proposed changes to optimize the vaccine process in the setting of a mass vaccination campaign. These deliberations and forthcoming recommendations will be used by CDC to inform state and local health departments to better prepare for an emergency response to a wide area release of Bacillus anthracis spores. As a reminder, when considering this evidence, the human data was derived from studies in healthy adults 18 to 65 years of age. Thus, the evidence is less supported in age groups outside this range or in special populations. So that is the end of the presentations, and I would like for the committee to see if they have any questions or comments or deliberations. We're particularly concerned, or would like to hear about the age of 2 to 16 for the antimicrobials.
Thank you very much. Questions? Yes, Ms. Pellegrini.
Thank you for all of this. Building on this question of children, I am wondering if the work group means for the first two questions here to also apply to children, in addition to the one about antibiotics. Yeah. I mean, I know this is a vaccine that's only licensed for 18 and up. The recommendations are for 18 and up. The evidence is for 18 and up. But is there an assumption in those two bullets that some children are going to get vaccinated, and so the dose sparing and such should apply to them?
Yes, that is. We believe that in a mass event that vaccinating everybody in the same way is important for operational issues. And then again, we also believe that there is the immune response in children should be robust.
Is there any intention to try to obtain, let's say, animal data for children or juveniles? Not animal data, but we have planned studies that if there is an event, hopefully not, but if there is an event, we will
collect data on the immunogenicity and side effects in children and older adults. Essentially in all the populations that we don't have data on.
Thank you.
Yes, Dr. Walter.
Yes, just a question. What defines a large mass vaccination event where you would switch to a dose-sparing strategy?
I think that is left up to the operational capacity of the jurisdiction that is where the event is happening. We don't have a trigger, but this is hopefully should be an exceedingly rare event, one that we would probably never see. But, we have to at least anticipate that we might come into this situation. And different jurisdictions will be able to handle things differently. So I think it is something that would be decided at the time, and that's why it is so important to have these type of discussions that we're having now done ahead of time.
Dr. Massonia, do you want to comment?
Yeah, I just want to comment that in the event of a mass event, there will be guidance coming from HHS, and it really is a question of whether the exposed population exceeds the vaccine supply. So it won't be completely left to the jurisdiction to make those decisions. This will be an anxious and hectic time, and those jurisdictions will be looking to CDC. And so the idea of this policy is to help CDC and HHS in the event of an event kind of put our arms around what that is. I also want to just add something to Cindy's question before Laura asks, so that the intention is also for pregnant women to be vaccinated in the assumption that the exposed risk is there, with the idea also that pregnant women would also be studied in the event setting.
Yes.
Dr. Bernstein?
Is there, with inclusion of pediatric population, is there a lower age, or that would be?
Well, the work group thought that 2-year-olds would be the lower end. So
There's no data, but
no data on anybody less than 18.
To clarify, though, you're discussing
Yes, the antimicrobial.
not vaccination, which is recommended down currently to
Oh,
any
down to
age.
6 months of age. Yes.
And so, just to clarify, so 0 to 2-year-olds, you're suggesting will remain in the for antimicrobials. Where will they go in terms of age duration?
So the 2 to 17-year-olds were asking if the committee, we're essentially asking 2 questions. If the committee is okay with decreasing the antimicrobial duration for the 18 to 65 years old, and then if they are okay with that, then if they are okay with 2 to 17-year-olds.
Which would mean that for 0, go ahead.
Dr. Walk?
And not for 0 to 2.
Henry Walk, the Chief Bacterial Special Pathogens Branch, where Willie is from. So the current plan is to give 60 days for under 18. And the ask is, can we go to 42 days for 2 to 17?
And what did the work group think?
Thank you.
This was a deliberation in the
Right.
work group, and there was a number of people in the work group and others here could speak to that, who thought that we could extend the 42 days down to 2 to 17.
Yes, so just to be clear that it is currently 60 days for everybody receiving the vaccine. So
Just to be clear from a working group perspective, this was a minority opinion. There are no data. And I think only a minority of the working group felt that you could do this. So
Yes.
it was a minority opinion.
That's specifically related to the 2 to 17-year-olds.
Correct.
yes.
Thank you. Dr. Atmore?
And I'll just add to that I think the majority felt that in the absence of data, whatever the risk group, whether it's pregnant women, children, persons over 65, immunocompromised persons, that the 60-day prophylaxis should be the default that's used. And it's really, the majority only felt that where there are data, 18 to 65, otherwise healthy, that it would be acceptable to have a shorter prophylaxis period for antibiotics.
Yes, that, I was hoping that that's what I had tried to get across, but that's exactly right.
Thank you for that clarification. May I ask a question? Did the work group consider what would happen if we use dose-sparing dosage in addition to using an IM route? Is there any consideration of how that would play out in terms of immunogenicity?
I think there was concern, and I'll let other members of the committee also speak, but I think there was considerable concern and discussion about the IM route of administration for PAP, given that difference at 28 days in particular in terms of the immunogenicity. So I think we revisited this on a number of occasions, and there was concern whether a dose-sparing regimen in addition to an IM would be a consideration. But the IM data, the dose-sparing data, it looks pretty good. Certainly 2 weeks after the last dose, whenever that dose is, the data look pretty good. But I think there was considerable concern on the part of the committee about use of the IM regimen, and only in situations where there was logistical issues where it couldn't be given sub-Q was the committee's opinion.
Well, so I think there are two questions here. One is in terms of the antibiotic prophylaxis duration, and there was a lot of discussion about whether it could be even shorter than 42 days, but depending upon the regimen. Based on the graphs that were shown, 42 days looked to be a good point where everybody who's gotten at least 2 doses by 42 days should have high levels of antibody. The sub-Q versus IM is based on that logistic regression model. And if you go back to slide 8, you'll see that there was only one non-human primate that had detectable antibody, had a high level of detectable antibody, that died after challenge. And all the other ones that died, that's the lower right-hand corner circle, all the other ones who died basically were at the threshold. And essentially, if you have antibody that's measurable in the non-human primates, with that one exception that's not understood, they were protected. And so, the question is, and the experts, most of the people I think felt going with the logistic regression model was appropriate. But, some wondered whether or not there should be a threshold effect. If you had detectable antibody, then you were protected. And so, but the consensus was higher antibody levels are better, and sub-Q at day 28 gives you higher antibody levels. So that's the reason for the preference for sub-Q over IM.
Yeah, this one non-human primate over here that died, it had developed anthrax meningitis, which is the presumed reason why it had a high antibody titer but still died, because the CNS is a immunoprivileged site and the antibodies were getting in there. But a good point is that if you develop almost any detectable level of antibody, you're protected.
Thank you. Ms. Pellegrini?
On the dose-sparing schedules, is the committee going to be asked to express a preference between 2 versus 3, and if 2, which schedule?
I think what we're asking for permission to use either one depending on the situation that comes. If we want to use, if we think that the 2 doses would give us the amount of vaccination we need, then that's what we'd use. If we think we'd have to do 3.5 or 3 half doses to expand it further, that's what we would use.
Dr. Romero?
On slide 14, the ACIP work group conclusions. So bullet number 4, you state that individuals that experience significant adverse events Will there be policy providing guidance as to what those significant events entail?
Well, that wasn't discussed. We could put that out there, but I think it would be in consultation with the vaccine provider.
That would be helpful, I think.
Dr. Fry?
I think we have to remember when we're trying to make up our mind about this very complicated questions with a lot of intricate data, that we're only being asked to make this decision or to use this response if there is inadequate supplies, given the number of people who are going to be exposed or the number of events even that occur at the same time. So that helped me think about this a little bit better, other than a single-time event. I do have a question about two questions. One, do we think there will be a limited supply of, for example, ciprofloxacin in this situation? I know vaccine is at higher risk at being at a lower availability. And do we have any data, or have there been any models looking at potential number of outbreaks at any given time, or events that could occur simultaneously?
Okay. Well, so for antimicrobials, we have a lot of PEP antimicrobials stockpiled. So the chances of those being a limited resource are very low. I can only think of a couple of situations where that would occur. One would, well, actually, the one situation would be if the organism used was resistant to one of our mainline antimicrobials. Then you might run into a situation where you didn't have enough. But no, the reason we're asking for a decrease in antimicrobials is twofold. One, we believe the data supports the decreasing it earlier, and just getting people off of antimicrobials earlier is a better thing, and will cut down on adverse events related to the antimicrobials.
Okay, could I ask for a motion? Oh, Dr. Massonier first.
Yeah. Hi, Henry Walk again. I think you asked about models to predict if there are models, both from CDC and BARDA and others, as we see the initial uptick in cases, to try to get a sense of how big the event might be. Of course, that's in one city at one point. There could be multiple cities.
And just to go back to what you said about the contingency planning, because that's what this is. It's contingency planning in case there's insufficient vaccine. We're also concerned about the needles. So there are much more stock of IM needles than there are sub-Q needles. And there's a potential that we just wouldn't have in the right settings, the right needles. And finally, I would remind you that there's also a new vaccine that is expected to be licensed. It's an adjuvanted anthrax vaccine. It should be in the stockpile soon, and it's an IM vaccine given at day 0 and day 14. So we're also anticipating operational complications with both vaccines being in the field at the same time, and the need to try to simplify in a chaotic time. So I just wanted to add to your operational complexities.
Yeah. We're going to talk about that vaccine later.
Thank you. Okay, I think I'd like to ask someone to make a motion for this vote.
Well, actually, so the bottom bullet there, I left it vague for a reason, because I wanted to get your all's input on 18 to 65 versus essentially 2-year-olds to 65. So at this point, if you how do we want to do this? I could put in immunocompetent individuals, age 18 to 65 years of age, and then the rest of it. If you all don't feel that there's support for the lower age.
I think I sense a consensus on this. Am I wrong? Yes.
Just a comment from the AAP. So we, on the working group and as the AAP COID, recommend for the third, the antimicrobial prophylaxis, 60 days for children, not to shorten to 42. But we also agree with the first two of IM when necessary and the dose sparing when necessary for children.
Thank you very much.
Okay, so if we could quickly amend the slide.
Ms. Pellegrini?
Can I raise a separate issue while that's being edited? I'd like to suggest we should consider expressing a preference for one of those alternative schedules. If I'm reading the charts right, in slide 16, which is very hard to read in black and white and very tiny, but the immunogenicity actually peaked most quickly with the 0-14 full schedule. And the 0-14 schedule, I think just based on human nature, is more likely to lead to higher levels of compliance. Because if people go a month without getting sick, some of them aren't going to come back, whereas they might come back in 2 weeks. So it's maybe a sort of language that kind of, I'm not going to phrase this properly, but all other things being equal, that we perhaps have a preference for 0-14.
You know, I will just say that is probably what we preferred, but during the deliberations, thinking that, I totally agree with you that waiting a month to come back and get it, you might lose some people, but just in the kind of mass event that we're talking about where this would ever be implemented, that we weren't confident that we'd be able to do it exactly at 2 and 14 days. So that's why we were saying at 0 and between 2 to 4 weeks. But if the committee wants to put, either 2 full doses at 0-14 days or 3 half doses at 0-14, 28 days, I think that would be fine.
Dr. Hunter?
Is that what you're recommending, Cindy? Or
I don't think I'm recommending, I don't think we should rule out 0-28 if for some reason logistically or otherwise that makes the most sense. But expressing a preference for 0-14 if circumstances permit.
Cindy, do you want it in the language of the recommendations or do you want it in our operational guidance? So we can do either, and the point is well heard and it makes perfect sense to us. I guess the question is whether or not you want to put it in this or whether you want us to make it part of the operational implementation of this.
Although 0-28 had the highest antibody levels achieved by day 42. So I think that the discussion...
Yes.
I would, as the chair, I would advocate for not putting it in here, but rather putting it in the recommendations that go with the advice about how to do this. And it could be clarified there that the 0-28 achieve higher levels, but the 0-14 may be preferable. And I think that's where it belongs.
I believe that's how we were thinking about doing it. Just we would put the data out and just say the 0-14 higher, quicker, 0-28 slower but longer.
Dr. Hunter.
So if the committee is willing to do this and to take 3 votes in order to move things along, you don't want to do that? Or you want to do the whole thing at once? Okay, I thought it might work better if we just picked off one at a time to move the discussion along.
How do others feel? I'm open to suggestions. I think our plan was to do all at once.
It's fine with me. I just wanted to move the discussion along.
Yeah, I'm in favor of just voting for it as one piece, and I do agree with having an operational decision in terms of recommendations, not in the official recommendation regarding the whether it's 0-14 or 28.
Thank you. Dr. Lee.
I just have one question for clarification. For the second bullet point, are we specifying whether it's sub-Q or IM? Or are we allowing flexibility? That's my only question in terms of evidence.
We are not specifying.
Unless you want to specify. Right.
That was my question previously. So it is possible that people would receive IM rather than sub-Q and then also receive a dose sparing. And we don't know what that would result in.
Yeah, so
I mean, again, I think this can be in the guidance. I think it can be clear in the guidance that, if an IM route of administration is used, that one might consider either, not using a dose sparing, or if you use a dose sparing, continuing antibiotics for the full 60 days.
Yeah, I agree. I don't think we want to constrain options given that there are no real data.
Well, can I counter that on the other hand? That I feel like the evidence tables were nicely presented to provide evidence for the sub-Q approach, and because of the lack of data, for me, it's a different question. So I think on the operational side, it may be completely appropriate, but in terms of the recommendation itself, I feel like that has to be where the evidence was shown.
I'm not sure I understand. So you're asking to vote on each one separately?
I mean, I would favor that the dose sparing is appropriate for sub-Q, and acknowledging that we don't have the data for IM. But in terms of the recommendation itself, I feel like it comes from those, ETR tables functionally.
I think that's fine. And again, unfortunately or fortunately, you're going to see this again pretty soon. So, in the effort to get consensus, if the word IM there makes folks more comfortable, let's do that. And then, sub-Q. Sorry, sub-Q. Sorry, sub-Q. And we'll ask the working group to look at the data again in the context of the new vaccine, and come back if there's any desire to change it, if that gets us to consensus.
Yeah, just to respond a little bit, I mean, my concern is that I think we're creating permissive recommendations here for an emergency in this country. And I frankly think that we need to give the best guidance we can, but make it as unrestrictive as we can. Because in the scenario that could happen, you might have to use IM, you might have to use a dose sparing. I mean, it's really not something that we can make perfect recommendations for, because...
I'd just like to say that the reason that we're doing this is that we know that getting vaccine into people's arms however you can will save lives. So we don't want to restrict getting vaccine into people's arms.
Dr. Bernstein.
So for me, in reading it and responding to Dr. Lee's question, I don't think we need it in the second bullet if we vote for the first. Because we're talking about, we don't need a preference one way or the other, because we're talking about an inadequate supply, which would then fall under one of the challenges. So if we vote for the first bullet, we don't need a route of administration for the second bullet.
Dr. Moore.
Just a brief comment in support of Cindy's position. Looking in the future, when we consider the new vaccine, I would love to be able to make a comment on the 0 and 14 schedule being preferred when at all possible, if supplies permit, because it sounds like that will be harmonized with that new vaccine as well. Operationally, as a program person who's been through post-exposure prophylaxis for anthrax in the past, anything we can do to shorten antimicrobial courses and shorten vaccine courses and go from 3 to 2 doses is going to increase the number of people adequately protected dramatically.
Thank you. I think we are still looking for a motion. Dr. Stevens?
So my motion is to approve as stated on the current slide.
Thank you. Is there a second? Dr. Hunter, thank you. Okay. Is there any further discussion, or should we move towards a vote? Dr. Belongia? No? Okay. Anyone else? I believe there's someone at the microphone in the back. I'm sorry, I don't know your name.
So it looks like we have one individual for public comment, and we do not have anyone else registered, but Ms. Woodruff?
Yes, my name is Andrea Woodruff. I've actually been quarantined a couple of times years ago in the Senate when there were some anthrax scares, so I had time to think about this a little bit. A common topic that's brought up is troops are vaccinated every single time that they're deployed, and so it'd be nice to see some discussion instead of just revaccinating, if titers can be checked or what can happen there. Considering it looks like the peak time for adverse events are going to be a little bit later, I didn't know how that was being considered when people were reporting those numbers. And also, as a parent, I would really, with the mandates and everything, I would really like to have the choice of what, if there's a scare, I would like to be in control over making the decisions to see if that vaccine is necessary for my child or not. That's it. Thanks.
Thank you very much. Is there any further comment, public comment? Any further comment from the committee? What?
Hello. Hi, my name's Erica. I'm with the group Health Freedom for Georgia, and I'm a concerned parent as well. Listening, this is my first meeting here, so thank you guys for your time and efforts on all of this. It's so very important what you guys are doing here. Listening to some of what you're talking about, trying to wrap my head around it, because I heard the lovely gentleman that presented talk about how we don't really know, what the risks are for children. But we still say that the benefits outweigh those risks. And I'm just trying to, understand and get how you guys come to that decision. I think it's an important decision, and it must be such a hard job for you guys to make these decisions without the proper information that you need to do so. So maybe if somebody could fill me in a little bit on that. And I, too, hope that there's choice involved when it comes to my child. If there is a mass event and you guys don't have safety information, I think it would hopefully be my choice as a parent, to decide if that's going to be put in myself and my family. Thank you so much.
Thank you for that comment, and I would refer you to some of the CDC's previous publications about the risks of anthrax and the ways of addressing them. Thank you.
Excuse me, I'm sorry, but could you please give your full name just so we can have it for the record, for the public record?
I did write a form, but it's Erica, Erika, Geiser, Geuser.
Thank you.
Thank you.
Thank you very much. Okay, so shall we call the question? The motion on the floor is to approve the recommendations as they are on the slide, and we can take a vote. I think we're going to try again, are we? No, we're not going to try again. Okay, so let's go around the table. Can we start with Dr. Bernstein and go to your left?
Bernstein, approve.
Moore, yes.
Belongia, yes.
Lee, yes.
Atmore, yes.
Fry, yes.
Hunter, yes.
Pellegrini, yes.
Szilagyi, yes.
Romero, yes.
Bennett, yes.
Stevens, yes.
Riley, yes.
Walter, yes.
Thank you. And so the recommendation passes with a unanimous vote of 14. Thank you all very much.